All right, team. Well, it is 6:30, 18:30. Excited. We already have a huge showing tonight for the next installment of MMC. This is an exciting night and kind of close to home for me because dermatology training, we took care of a lot of wounded warriors, and these were definitely some of the most meaningful cases. Again, standard disclosure. Thank you. We are working tonight with the kind of local physical med and rehabilitation group, as well as plastic surgery, and then the Association of Military Dermatologists, as well as war docs. For those of you that are on there that enjoy the stories and want to hear more opportunities, War Doc, they host a website with a wealth of information and great stories that you can learn about from past physicians that have served. Again, at the bottom of the USU MMC website, if you are interested, I know we have a lot more HPSP students on tonight, which I'm excited about. If you are interested in starting your own local chapter where you can get together your Army, Navy, Air Force fellow students and create your own little groups where you guys can study, support each other, start building your Rolodex now. All of that is there and built. Just reach out to us and we're happy to help you guys sort that out. We can find local military physicians, retired or separated, that would be interested in helping you guys along the way, along your course. And I'll turn it over to Dr. Newkirk. Are you on there?
Yes. Thank you, Dr. Cox. So it's my honor and privilege to introduce our first speaker, Dr. Sabino. She's the DSS, or Director of Surgical Services at Walter Reed. So basically, she's in charge of all the surgical care at the hospital, which is a huge deal. She's also a graduate of West Point and Yale School of Medicine. So, Dr. Sabino, over to you.
Good evening, everyone. Thank you for the introduction. Just a little bit about me and my path. I'm from Connecticut. Have a younger brother. I, kind of had a typical kind of elementary to high school experience, played some sports, ended up applying to West Point for the class of 2005. A lot of questions I get is, do you have a military background in your family? Why did you decide to go to West Point? And I have to say, my grandfather was in World War II. He was drafted and then immediately got out when the war ended. So while I do have a military legacy, I wouldn't say it's, part of the long gray line. But being West Point being relatively proximal to my house, I thought it was a path less traveled, and I never looked back. So I spent 4 years at West Point. I was a physics major. I was not pre-med and didn't go to college thinking that I would end up pursuing a career in medicine, but here I am. So through those 4 years, I had a lot of great experiences, and I did end up taking the classes that would prepare me for medical school. Chose to take the MCAT so that I did, have that as an option. And then at West Point, you have to apply in order to be allowed to apply for medical school, which is true of a lot of the academies. So I applied, was accepted, and then I applied to medical school and I went to Yale. People will also ask me, why I went to Yale instead of USU. And I did apply to both schools, but after 4 years of West Point, I thought that getting out of the uniform for a few years might be a good opportunity. And it was definitely a culture shock, but also a good experience. I did a general surgery residency at Walter Reed from 2009 to 2015. If anyone's familiar with those years, those were some of the surge years of OEF and OIF. So we had a lot of casualties coming in, and that's what first sparked my interest in plastic surgery. During those years, I did do research into limb salvage, and we'll kind of talk a little bit about that. But it prepared me very well for applying and then getting into a competitive specialty like plastic surgery. I went to Johns Hopkins for a 3-year independent plastic surgery training. So there are 2 paths to go into plastic surgery. One is integrated, where you just do a plastic surgery residency, and the other is called independent, where you do a full other residency, most commonly general surgery, but sometimes orthopedic surgery or a variety of other subspecialties. And then you do 3 years of plastic surgery. So that's what I did. So I'm a fully trained general surgeon and a fully trained plastic surgeon and board certified in both. I left home for a little while and went to Madigan after my training. I was the only plastic surgeon there for a while, and I was there for 4 years. I think it was a really growing experience to kind of go out of your comfort zone from where, where you don't know everyone. During that time, I was deployed to Kuwait for 6 months. And now I'm back at Walter Reed. I got here in 2022. I have held a variety of admin positions, but first and foremost, I'm a plastic surgeon who basically operates like head to toe from birth to 100 years old. All right. So the most important part of like my career here is the plastic surgery team in the National Capital Region. So most of us are at Walter Reed, but we cover all the hospitals in the region, and we operate everywhere and see patients from south of the Beltway, north of the Beltway. And we all have kind of a very broad practice, but have carved out like a niche for ourselves. So this is the team. I'm very blessed that, these are not only like excellent surgeons, but they are honestly some of the best friends I've ever had. So I would say when you're choosing, what you want to do, think of the people that you're going to be working with, because that will sort of make or break your experience, no matter how you feel about like the actual work that you're doing. So everyone is great. I'm super lucky to be working with every one of them. They have taught me so much. We support each other. We hang out together. Couldn't ask for more. All right. So war, trauma, and plastic surgery. Basically, plastic surgery kind of grows leaps and bounds when we are in conflict. And then when we are out of conflict, those lessons learned during the war years translate over not only to just civilian trauma, but in general to taking care of patients. So at different intervals in history, plastic surgery has really changed the way that we practice medicine. From World War II, when we kind of talked about facial reconstruction, World War I to World War II, when we, with antibiotics, burn treatment, and skin grafting, and then the modern era. I remember as a resident at Walter Reed, you could tell where a patient was coming from without looking at their medical record, just by their injury patterns. And extremity injuries, which we're going to talk a little bit more about, kind of defined that injury pattern. So in Iraq, most soldiers were mounted, meaning they were in vehicles, and the IEDs, when they hit the vehicles or when the vehicles ran over them, the vehicles would either flip or kind of bounce up and down, and that produced a very specific injury pattern, which was usually calcaneal fractures, so fractures of like the feet, compression fractures of the spine, and then kind of shearing injuries of either, the back or the torso. And that would result in, a lot of extremity salvage. On the other hand, because Afghanistan is so mountainous, people would come in with, they would step on IEDs rather than being in a vehicle when it happened. And so they would have lower extremity injuries, usually amputations. And then from the way they held their weapons, they would have very specific injury patterns of either one or both upper extremities. So we were doing a lot of limb salvage. And again, the lessons we learned during that war, when we would get 3 to 5 patients 3 times a week with these kind of injury patterns, now has crossed over to not only civilian trauma, but civilian limb reconstruction in general, like from cancer, from infections, that sort of thing. So some of the research I did when I was a general surgery resident interested in plastic surgery, you can still see translated today at shock trauma or at Hopkins. So that's really exciting and really rewarding. And I have to tell you, if we get into another conflict in the next 10 years, we will learn a whole new set of lessons that will then translate to the way that we take care of patients for decades to come. So the pictures here in this slide, that's all one patient. That is a very typical injury pattern from Afghanistan, like I was talking about. And in this patient, we did a variety of reconstructions to either salvage his existing limbs or set up his limbs for, amputee care and maximizing the function that he's going to get. So in this case, We did a variety of tissue transfers to get stable coverage so that the orthopedic surgeons can do their fracture fixation. But it's really a team approach with these kind of polytrauma patients where multiple subspecialties are working together to get the patients kind of acutely fixed or subacutely fixed and then rehabilitated to become functional. So a lot of these patients, went on to like run marathons or compete in the Special Olympics or, be fully functional and even like redeploy, which again is super rewarding. I told you, these things that we did during the war years have kind of translated over to, my practice at Walter Reed and every one of those like partners practices. So in the upper left here, this is a gentleman who had a soft tissue infection that he ended up actually losing both of his legs and both of his arms. And we did a tissue transfer, not to salvage his limbs. They had already been amputated, but to optimize his limbs for rehabilitation and prosthetic fitting. So we were able to save, a little bit of length so that hopefully someday he can wear a prosthetic. In the upper right corner, that is a gentleman who had a soft tissue tumor of the dorsum of his foot. So again, we did like a tissue transfer, and he was able to be fully functional on that foot again, even though after the resection his joint was exposed, and he had like a functional deficit at this point. In the bottom right, that is a gentleman who had a motorcycle accident while he was in Germany. And we actually used part of his omentum, so some of the tissue that was in his abdomen, to cover up some of that hardware so that he could eventually be skin grafted and then salvage that joint. Yeah. And those are just some additional cases. So we do really cool things every day. But that being said, plastic surgery in the military is an incredibly broad specialty. So one day I could be doing one of these cases in the operating room for 12 hours. And then the next day I can be doing, 4 eyelid surgeries and be done at noon. So it's a really cool niche in plastic surgery because you can maintain a very broad practice or focus down and do a lot of very long lasting things to benefit patients, especially our war wounded. I think that's all I have.
Thank you so much, Dr. Sabino. That was kind of exactly like what we were looking for, that overview of plastic surgery and your sharing your story. There you go, you get the applause. I totally agree with you when it comes to the, find your people. And that's one of the pearls that I threw out there to, medical students. When you're in morning report, look around that room and see how many people in this room do I want to go on a 2-week vacation with, have a, dinner with tonight, because those are the people that will, 10 years from now, you'll be sharing an office practice and a business model. And so I definitely appreciate that. And thanks for all the hard work you do for all the wounded warriors. Those were really tough days at Walter Reed in that 2009 to 15. I was looking at PM&R. Anyway, all right. Thank you so much, Dr. Sabino. I appreciate you. We're going to move on to what happens after the surgery. So what does the next 18 months look like? So we've got Lieutenant Commander Dan Wido from Physical Medicine and Rehabilitation. And this is a really cool specialty that a lot of people have not heard of. And so I'm excited to share this part of medicine with you guys. So Dr. Wido, over to you.
All right. Thank you, sir. Appreciate everybody for joining us tonight. Again, no significant disclosures. I'm Dan Wido with the Physical Medicine and Rehab Department. We're going to talk a little bit about really kind of what PM&R is. It's kind of one of the lesser known entities within the hospital, but then when our footprint does exist, we certainly get a lot of good working relationships with other people. A little bit of my unique path to medicine and PM&R, and then kind of how we function within this Amputee Care system. PM&R is also known as the physicians that are physiatrists, and really we're trained to treat disorders of the muscles, bones, nervous systems to restore function, reduce pain, and improve quality of life. And so really one of the big pearls for when you're rotating with us, having those good neuro and musculoskeletal exams can really help you stand out. But it's really that foundation of how we have people interacting with the world around them and getting people back to their goals and to doing the things that they want to do in the ways that they want to do them. And so
it's a specialty that was actually born out of recognizing complex issues for veterans returning from World War II. This is a picture of our forefather, Dr. Frank Cruzen, who started the first program. And so it's very unique to be able to practice within that setting in the military, to be directly involved with the care for a lot of these individuals that really created the birth of our specialty. My path was initially through biomedical engineering at the Illinois Institute of Technology. I had a love for science and math, and really wanted to figure out a way to apply that to the body with family that served in the military, and having the wars in Iraq and Afghanistan going on. That certainly shaped some of my professional goals. But my route ended up going a little bit through graduate school, again in biomedical engineering, but longitudinally enjoying sports, enjoying activities, and doing some volunteer work with things like the Special Olympics, really showed me that, those are some areas within life and within medicine that I enjoyed and wanted to help support. And so to see athletes of all abilities getting out, getting together, socializing and competing and having fun and taking care of their bodies, really created that context for me. And as I was, creating my professional path, it pushed me towards medical school, to get out of the lab with no windows and no people, and really pursue something a little bit more social and working with others. And so that led me to the Uniformed Services University. The picture of my fire team at our white coat ceremony, the people that you work with, your study groups, your lab partners. And within military medicine, I've learned a lot of elements that, there's going to be some unique opportunities that you really are going to get that other places just don't have. And part of that, during medical school, was going down to Fort Rucker, Alabama, and getting to practice IVs in the back of a helicopter with my classmates. And then, as military doctors, we never really know what setting we're going to be practicing in. And so being aware of a lot of the tactical combat casualty care and preparing for field exercises is another big element. So that's me before a Bushmaster exercise, getting some moulage done on my leg there. I got to train in a lot of different places, meet a lot of different people, but really, throughout med school, I kind of enjoyed everything. I, thought I could see myself being fairly happy in a lot of different specialties. And so that led me to choose a transitional year internship. I went to Naval Medical Center, San Diego, doing electives in anesthesia, dermatology, orthopedic surgery. But the ultimate goal was to be a flight surgeon, to take a little bit of time, get to do some further unique things. And so it led me down to Pensacola, Florida, and got to fly some helicopters, fly some airplanes, and then bring it all together and learn about how that medical piece plays into creating aviation safety and supporting people that are in the aviation communities. And so I initially started out with the mighty Sea Elk of VMM 166 out in San Diego, an Osprey squadron, did a deployment out to the Middle East and detachments for training throughout the U.S. And then I did a subsequent flight surgery tour with VQ-1, the World Watchers, Air Reconnaissance Squadron. This is a picture of us doing a joint exercise with the Japanese defense system out in Okinawa. And so as a flight surgeon, you get to go around the world, work with a lot of great people while you're being a dedicated primary care physician. It helped me learn that I really wanted to be involved with the care of people, getting them back to their jobs, getting them back to do what they wanted to do. Primary care was interesting, but it wasn't quite specialized enough. And thinking back to my surgery rotations and stuff, the tempo and the lifestyle was interesting, but it wasn't exactly the way that I was looking for, and really just kind of working together with the people and getting them back to their jobs, their occupations. And sometimes there were times people had diagnoses that didn't let them go back to being pilots or whatever they were doing, and working through their medical issues and getting them to be able to maximize their opportunities was something I really liked. And so I, got in touch with some other friends who had done physical medicine and rehab programs, because I really loved that musculoskeletal component, loved the nervous system and the neurology exams, and was fortunate to get picked up and come over to Walter Reed for residency training. And so there's a picture of my residency class and fantastic program leadership. And while you're in physical medicine rehab residency, you're doing a lot of unique things. And part of that is learning more about that nervous system, doing things like EMGs in that top left corner, studying nerves, getting to understand how they're working, maximizing your anatomy, both with ultrasound and fluoroscopy in the center pictures. We do a lot of ultrasound and fluoroscopy guided procedures to help apply medicines and treatments into places that we can localize at the bedside, all short of kind of the operative interventions. And then we also do a lot of work with, very unique patient populations. So that amputee care, spinal cord injury care. And so part of that is understanding what patients are using and how they're able to interact with their environments. And so, in the bottom left corner, playing wheelchair basketball with your patients helps you understand who's appropriate and ready to make that transition. And then certainly being academically minded and working in conferences, making friends with Dr. Glockenflocken, who's a legend on social media, is also part of the game. And so PM&R, we distribute our care in a lot of different ways. Our clinics are set up to have different arms where we can get patients through each level of our services. And then we have a broad breadth of patients that cross a lot of different specialties. And you'll see we take care of amputees a lot, but brain injury medicine, complex wounds, other muscle and nerve disorders, we kind of have a little bit of a blurred spectrum. So there's a lot of unique patients that you get to encounter throughout PM&R. And with unique patients come unique problems and longitudinal care. And so that's why we work very closely with a lot of different allied health specialists, therapists. Our clinic setting isn't just a sterile room. Our clinic setting is the gym. It's, out on that basketball court. It's, in the therapy spaces. We use a lot of ways to objectify where patients are so we can monitor their progress and their return to function and health. And so, just a quick snapshot, we have incredible teams, a lot of great physicians, orthotics and prostheticians who help with the actual fitting and devising those limb replacement devices. The therapists, everything, throughout the hospital, there's a lot of steps as Colonel Sabino was alluding to and Dr. Cox was talking about the next 18 and beyond months. We're still taking care of a lot of Vietnam veterans who had amputations and longitudinal care needs. And so to be able to be ingrained in each step of that injury pathway is a pretty special thing. And then to be able to get people from that critical time to, back to, high level athletic endeavors is a very rewarding piece of our field. And so for amputee care, there's a lot of different components that go into it. And so partly, we need to know who we can refer to when they're appropriate to get fit, when they're able to, tolerate the therapy that's required. And so that's why it's, when you're rotating with PM&R, thinking about how the patient and their status is and how it's impacting their ability to interact with that world around them. How their sound limb is. If someone's got an amputation on one side, but then knee pain on the other, that's going to impact them as well. So you want to make sure that you're considering that whole patient and their whole experience. And certainly with restorative devices like these prosthetic devices, there's a lot of options. And there's a lot of need. We have over 2 million people in the U.S. living with limb loss. Over 1,500 people had amputations as a result of the wars in Iraq and Afghanistan. And as people live longer, they're going to need more long-term care needs for these problems. And as some of these experiences with the blast injuries and everything, there can be a lot of comorbid problems as well with brain injuries, other limb trauma, other nerve injuries, burns, infections, sensory loss. And so, again, we really want to make sure we're cognizant of everything that patient is experiencing to maximize that return to function. And as they're going through each step of the way, there's a lot of things that they're going to need to adjust to. And so there can be some other confounding things that you need to address, how that person's interacting and where they're living, who's supporting them, are there other mood issues that they're needing to deal with, and so as physical medicine and rehab physicians, we really want to make sure that we're good quarterbacks of being able to distribute care and find what patients need, because we're there for a lot of these longitudinal steps. And so, as we learned from the wars on terror, there's a lot of different injury patterns. And so we see that, most of the time people had those lower extremity injuries, but then people also had multiple limbs that were impacted. And so that transtibial, that below the knee amputations and transfemoral amputations above the knee. And so what we think about is what's missing, what do we want to restore? How is that person doing functionally? And what are their goals and what are they trying to do? And that can help us figure out systems for getting them more mobile and getting them doing the things that they want to do. And so for attaching a prosthetic device to someone, there's osseointegration as seen on the left, where there's a surgical implant that's attached to the person's skeleton that then comes to the outside and we're able to fit with devices. And then on the right side, you'll see some other pieces that have some socket where sockets that attach to the body and hold the soft tissue, and then are either held on by suction or different ways to keep it on the body. But getting the device onto someone is the first step, and then replicating and replacing each of those joints that you're looking to restore is kind of that other step. And so we do lower extremities, but we also do upper extremities. And with the upper extremity, you're also trying to interact and restore someone's ability to do grasp or other hand tasks. And so we have one mechanism of doing so where we use the person's body and what kind of natural movements that they can do to impact and influence what a terminal device is. And so on that right side, you can kind of see that at the very end of it, there's a grasp tool that someone can actuate by moving their shoulders forward because they have this harness suspension. But then we can also use what's left over, those residual muscles, for like myoelectric control systems. And so there's a lot of very unique technologies that we can use to restore someone who has, catastrophic limb loss to do the things that they really want to do. And so on the left, there's a dual site control that really can just open and close. But then we use a lot of RS, and you can see that rest of the hand looks very real, and it can help people adjust to that loss with that visual. On the right is a COAP system for a bilateral shoulder discharge, or a bilateral upper extremity amputation for somebody. And there's a lot of sensors that are built in to that prosthesis, and we can train how that person then can control different motors to influence how they can move through the space and interact with objects. And that's why, it's a very multifaceted team game, because we need to get people to the orthotists and prosthetists who work with the construction and assembly of the devices. Then we need to get them with the therapist. We need to make sure that all their other problems are managed well. And then the therapist can use that phone and program different motions to then help that person interact with the world, wash dishes, pour milk, just simple things that we take for granted. People that have amputations still have problems, right? With the complex blast injuries, we see people that have a lot of retained shrapnel and fragments. That can be a barrier for finding good fits and good prosthetic devices to help that person move through the world comfortably. And then similarly with OI, the skin is always going to be there, and then it certainly can have issues. And that's why we work with all of our colleagues from plastics and dermatology, as well as all the surgical subspecialties, because we really want to make sure that we're advocating and supporting this patient and their ability to use the devices that we're prescribing them. The body, as it goes through significant trauma, can have abnormal physiologic responses. This is a patient who has a condition called heterotopic ossification, and that's where the body is just laying down tons and tons of bone. And you can imagine somebody who is using one of those sockets, if your body is getting externally pressured from the outside and you have those sharp pieces of bone, that's going to be pretty uncomfortable. You're not going to want to wear that socket, and you're not going to have that restored limb. And so that's what led this person to pursue OI. And then, you really want to bring all your tools together. We do all that ultrasound training, we do all that clinical exam. And so, patients with even long-standing amputations are going to have issues. And so to be able to identify things like this person who has a significantly inflamed bursa impacting their ability to wear their prosthesis, it's important to kind of bring everything together to make sure that people are moving forward and comfortable and getting what they want. And then finally, once you've got someone stabilized, then you can really start to get them doing the high-level activity things and give them some sports-specific prosthetic devices. On the left side, we see some running legs. On the right side is a snowboarding leg or skiing leg, and it allows some more pressure dissipation on the right with that winter sports leg. And on the left side, you get a lot more energy return, so you can have people like Oscar Pistorius doing those high-level Olympic sprinting activities. Because, you've got patients that have catastrophic limb loss. And like this gentleman, months before this picture, they had lost pieces or all of all four extremities. And we come in after they're surgically and medically stabilized. We work with them to build up their endurance. We work with the therapists. We work with the team members. We work with the prosthetists to get the right devices. And then we work with the adaptive rec people to get them these opportunities to get back on the mountain with their friends, doing things that they like, reintegrating with society, and really just having an overall positive experience from a very significant personal injury and problems that then can certainly help us have them get a little bit more enjoyment and do well in society. And so, really, in short, there's a lot of things you can do to excel in the PM&R rotation. There's things like, knowing your joint exams, knowing your neuro exams, being a good team member, and then, being, in the military. So having good grooming standards, wearing your uniform, being on time, being respectful. Those are things that are going to be good for you, no matter what specialty you're looking at. There's a lot of options in PM&R. There's specialties, there's further subspecialization, but really, you're coming together to help support that mind, body, and spirit to restore function. I love it. It's, I'm very fortunate to work with such a great team of people and animals alike. Service dogs and service animals are certainly a big part of, getting people back up and at it. You've got shared goals. Your clinic isn't just a clinic, and you certainly have a lot of opportunity to move science and healthcare further. Definitely appreciate everybody for being on tonight, for the motivation, and specifically Dr. Sparling, Dr. Pasquino, Dr. Dolomishevitz, for the guidance and assistant presentation, and everybody in the Department of Rehab for all their support.
Thank you, Dr. Wido. That was an excellent session. One of the most rewarding blocks that we have in our derm residency at Walter Reed is being able to work with you in the PM&R clinic during our multi-specialty clinic month. And we're able to see some of the most memorable amputee patients in that clinic. So we're grateful for your time and your expertise. And so after rehab, one of the next items to work on is treatment of scars. And up next, we're fortunate to have Dr. Bichkovsky joining us from the Tampa VA, who is also a host for dermatology residents as an elective experience. So Dr. Bichkovsky, over to you.
So dermatology involved in Amputee Care is maybe something a lot of people don't think about. And I think that's part of why Dr. Cox invited me here today. Dermatology, a lot of people think about skin cancer, psoriasis, eczema, acne, maybe even aesthetics and cosmetics. But one of the unique things that I've been able to carve out in my career is clinically run at the Tampa VA, and it's called cutaneous rehabilitation. So essentially, we're using lasers, lights, energy-based devices, a lot of equipment that was built for aesthetics and cosmetics. So we're using that to treat burns. We're using that to rehabilitate scars. We have a very large Amputee Care center that it's paired with the regional Amputee Care Center here at the Tampa VA, and we'll go more to those details. But I'd love to tell you a little bit about my story and how I ended up here. So first, dermatology, VA, Amputee Care, why? What is the need? So when we talk about all the solutions, the unmet need here in the VA population, we have over 95,000 veterans that receive amputation care within the VA. The VA is the largest socialized healthcare system on the planet. So we take care of all the veterans after they leave the military. Prosthetic users have a lot of skin problems. Why? The interface between the prosthetic and the skin. You have problems with friction, you have problems with humidity. To the point that 15 to 41% of ambulatory care visits for amputees include some type of dermatology patient concern. So we'll talk a little bit more about those. But so how did I end up here? So my background, I'm a graduate of the United States Air Force Academy in 2004. I went on to Uniformed Services University, where I met Dr. Strepa, met Dr. Cox. Went on and did my transitional internship at the San Antonio Uniformed Services Health Education Consortium, SAWSHEC, very long acronym, down in San Antonio, working between Burke Army Medical Center and Lackland Air Force Base. From there, I knew I wanted to go into dermatology. And this changes year to year, and all the services are a bit different. But at that point, long time ago, in order to go into dermatology, the Air Force was requiring their applicants to have some type of operational experience. So that means you can either go to the field as a general medical officer, where you're really like the primary care provider working in a general health clinic, or you can go into flight surgery, where you're a primary care provider working specifically in flight operations, flight medicine. We heard a little bit about that from Dr. Wido. So I grew up watching Top Gun. I thought flying was cool. So that's definitely where I went. And I'll show some pictures, talk a little bit more about it. But I think the military provides some really unique opportunities that maybe it starts off, it sounds fun, but it really gave me a lot more appreciation for soldiers, sailors, airmen. You get beat the pointy end of the spear. You get to take care of the guys out in the field. And it really drove me ultimately to keep my career going to the VA. I feel honored to continue to serve for those who serve and have served. It's something that I can't see doing any other way. After flight medicine, I came back. I did my residency in dermatology back in San Antonio, and did a couple of tours as a staff dermatologist back on Air Force Base, Randolph Air Force Base. My last active VA assignment was at MacDill Air Force Base, which is here in Tampa, Florida. From there, I transitioned to off active duty to the Air Force Reserves, which is I made uniform today. I was working for the Reserves today, and then I worked full time in my civilian career at James A. Harvey Veterans Hospital here. Unique opportunities throughout all these programs. Most recently, the VA sent me out to do a secondary fellowship at MIT in Boston in medical innovation. We can talk more about that offline if people are interested. But I think military, government, there's a lot of opportunities that are out there. So if you're a finder, if you're good at searching for opportunities, you're going to have a lot of things that you can accomplish. As a flight surgeon, depending on where you go, what units you're assigned to, you'll find an aircraft. My first unit was an F-16 unit, and they put my name on an airplane, which I think is probably got to be one of the coolest things I've ever done. So that picture stayed with me for a long time. But I've been in Blackhawks, I've been in B-52s, KC-10s, KC-135s, C-5s, just a number of different aircraft. You get to work with the boom operators, which is what I'm doing here on the picture on the right. They literally lay on their stomach with their chin on the chin rest, using joysticks to put the boom of the refueling tanker into the inlet nozzle, whatever aircraft they can be refueling. So you learn a little bit about ergonomics. It's our job. The different aircraft, they're all different. So part of military medicine is being there with the guys, the girls, seeing how the job is done and experiencing with them. And that's something that's part of flight medicine. And something's been very important to me. Fast forward in my dermatology career, yes, we do things like skin cancer, we do things like warts and eczema, inpatient dermatology. So Dr. Pesiak in there, we have medical dermatology where we take care of severe inpatient-related dermatologic disease like adverse drug reactions and reactions to chemotherapy, other blistering bullous disorders. Oftentimes these patients are very sick and they're in the burn unit, ICU, and things like that. But you also get to meet really, really interesting people. So Dr. Pimple Popper is probably one of the most famous people I've met. She put together an opportunity a couple of years ago trying to raise awareness for skin cancer by jumping out of a perfectly good airplane. I thought that was a great idea. So I signed up. I got to work with her and some other well-known dermatologists in the theater here and have some fun. So what a great opportunity. But moving on, so Amputee Care, you've heard a little bit about it from the surgical side, from the PM&R side, more specifically from the dermatologist side. The friction in the environment in which prosthetics exist, that interface can resolve a whole lot of problems. In dermatology, we have this thing called the Band-Aid sign. If someone's got a Band-Aid on their skin, you need to take it off and you need to look into it. It's the same thing for amputees when it comes to clinic. You need to take their prosthetic off. You need to take their liner off. You need to look at the liner. You need to inspect their skin. And you need to see what's going on there. Oftentimes, you'll see different types of problems. Chronic ulcerations, like you see here on the left, where the wound edges are white, they're sclerotic. This wound isn't healing. So you're going to have to do something to stimulate that to close. And we do this in both surgical and non-surgical ways. Secondary infections can be quite common. Anytime you get skin breakdown, you already increase the risk of skin and soft tissue infections. If you could smell through Google Meet and virtual meetings, you would know that this is very infected. But this is, you use all your senses here. Obviously, it looks bad, but how you care for this often results in somebody staying out of their prosthetic through laying for weeks or longer. So it can be very inhibiting for those members to be off their leg, back in crutches and things like that. So oftentimes they might avoid care for that reason. So what do we do for these veterans? What do we do for these service members? How do we care for them? If we can make a residual limb smooth, we can make it hairless, and we can make it sweatless, you get a lot less friction. So what you're seeing here is the treatment or pre-treatment to prevent folliculitis. So inflammation around the hair follicles, ingrowing hairs, whether you're used to shaving your face, legs, armpits. I think we've all probably experienced ingrowing hair at some time. But for an amputee, this isn't just a minor annoyance. This can turn into a skin soft tissue infection. Oftentimes, the ingrowing hairs, if the inflammation is chronic, we see sinus tracts and fistulas that often have to have major excisions, which means more time out of their leg, which has big impacts on quality of life. So we see this every day. We have 3 providers in my clinic that provide temporary laser hair reduction, scar treatments, all these things in combination with our amputee regional amputee care clinic. There's different ways this is done. These are all different lasers used for hair reduction. These all come from the cosmetic and aesthetic world, but here we're using them for medical intervention, and it can result in a major improvement in care and reduction in skin inflammation in hair patient. It does take a little bit of advanced training doing this on an amputee versus a non-amputee. There are some subtle changes and differences, things you have to think about. Sometimes you have ectopic ossification, sometimes you have neuromas, sometimes you have skin breakdown. Sometimes these veterans are going to be at increased risk of infections due to other comorbidities. I think inherently we often think of military and we think of blast and traumatic limb loss, but in the VA setting, you see a lot of patients with vascular disease and diabetes, other reasons that they might have limb loss that may contribute to increased risk and the challenges they're continuing to deal with. In addition to laser hair reduction, laser hair removal, one of the major services we offer is simply sweat reduction. So if you can make that limb, as I mentioned earlier, dry or reduce the amount of humidity or moisture that's created, you get a better fit. In the most dramatic form, if a liner becomes so saturated with sweat, the entire liner can come off, and that causes instability, and people can fall out of their prosthetic and fall down. It's more often, more common, it's about to get loose rather than complete loss. So the way that we do this in our clinic, what you'll see on the far left is residual limb covered with a topical anesthetic. It's a combination of 3 anesthetics, pendopine, lidocaine, pipercaine. We have cleaved that with some type of plastic wrap. We let that anesthetic set up for 30, 45 minutes. That's a little variable. And then for injections, we tend to use these multi-injector needles. And this isn't super common. Hopefully this is something that can be useful for some of the other people on the call here. But these are 1/4-inch mesoram multi-injector needles, which makes injection time much faster, much shorter. And these are very sharp, very short needles, so we can cover a lot of area very quickly. So, and we're injecting Botox, Dysport, Xeomin. These are all products, the same things that make wrinkles go away. They also make sweat production stop. So, how much product we use may vary on the size of the residual limb, but we've used upwards between 400 to 500 units of Botox, Xeomin, Dysport, that's without any side effects. There's other ways to do this. There's energy-based devices that use microwave energy to release. There's topical products and roll-on products, but this tends to be one of the most practical and effective techniques for taking care of these patients. But it doesn't last forever. We have to repeat this usually every 3 months or so. So we try to do this in an environment that causes as minimal discomfort as possible. Again, that's why we're using a topical anesthetic. We're using a needle for HCC therapy. In terms of scars, this is something that's near and dear to my heart. Scars is a big part of my practice. Wednesday this week, I take off for Milan, Italy, and speaking at a conference called SCARS, an international conference dedicated to treatment of cutaneous scarring. We do clinical research at the James Haley Veterans Hospital. We partner with Physiatry, PM&R with these programs and some civilian dermatology programs. But scars are not just something that you see. It's not just something that impacts people in terms of appearance, but functionally, a lot of these scars result in chronic pain. They result in chronic itching, pruritus. They result in poor wound healing. If this is an area where there's a hypertrophic thickened scar, and you have some type of a liner, a residual, a prosthetic that's putting pressure on that area, it can cause quite a bit of discomfort. So we use a number of different laser approaches to treat these scars, whether we're using non-ablative lasers, things like a 532 KTP, 595 PDL, pulse line laser. These are devices that are often used to help treat erythema and flushing, but the heat they produce also causes quite a bit of rehabilitation of the scars and can fight those out. So the thicker, more ropey scars, those that have more tension on them, opposed to going directly to surgery, they can treat these patients often very safely in an outpatient setting, which is what you see here. This is my just outpatient dermatology clinic at the VA. These are fractional ablative resurfacing. So the analogy I use here, this is kind of like aerating the lawn, if you know what that means. The lawn guy comes and he makes little holes in your lawn in your backyard, adds the fertilizer on top, and then everything goes better. In a similar fashion, we make a lot of itty bitty little holes that are, when I say itty bitty, microscopic, 120 to 170 night columns. You put 1 to 3 millimeters of it in there. Very small. These things tend to re-epithelialize. It goes up within just a couple of days. But the process of doing that reduces a lot of the tension on the scars. They can flatten out. It results in neovascularization, so we get things like muscle growth. We also develop neocollagenesis. So collagen is kind of the structure that helps support the skin. And doing this repetitively every 4 to 6 weeks over a series of months can result in a major improvement and not only how the scars feel in terms of a reduction in pain edge, but it can also reduce quite a bit of pain. The study that we have ongoing right now at the James Bailey Veterans Hospital is showing significant improvement in sit-to-stand times, 5-minute walk times. So we're now starting to incorporate some of these more measures you would use in PM&R for function. So we're not just judging what the scars look like, but we're judging the impact on what happens when you make these better for the veterans and for the service members. I'm happy to talk more about that or just dermatology in general. This is my email. You can leave it up here. Anyone could be very happy to reach out. Dr. Newkirk mentioned if there's other residents, acting team members, anyone in general. I have rotators at my clinic all the time in Tampa, Florida. So depending on your training, where you are, there may be some requirements. But if that's something you'd be interested in, it's feel free to reach out.